Hello, everyone. Welcome to the TSU Baylor College of Medicine P20 Cured webinar. My name is Brittany. I'm the program coordinator for P20 Cured. And today's webinar is comprehensive cancer care in a hospital setting or in a safety net hospital delivery at all levels. Thank you again for joining us. Just some general announcements. There will be a question and answer session at the end of the speaker presentation. And so make sure to post your questions in the Q&A box. Again, thank you very much for joining us this afternoon. To kind of just go over P20 Cured, the P20 Cured program is the Partnership Collaborative Union for Cancer Research and Educational Development. It was the only grant funded in the U.S. In the specific cycle that it was in. Through this award, we developed an alliance with Baylor College of Medicine for cancer research, education, and community outreach, training and promoting the biomedical research workforce, and supporting a pipeline of innovative cancer research pilot projects. So this is our amazing team and the overall impact that P20 Cure program does, including from pilot projects, increasing investigators, conducting cancer health research, improving cancer health research programs, promoting the development of cancer research, and things of that sort. So before I introduce today's speaker, please make sure to complete the survey for community members. And if you are here for a CHWCE credit, please sign in and complete the evaluation. And so now I will introduce the speaker for today's webinar, Dr. Martha Mims. She is a professor of medicine in the section of hematology/oncology at Baylor College of Medicine. She's the former hematology/oncology section chief and presently serves as section chief for hematology and oncology at Harris Health Ben Taub Hospital and Smith Clinic. At present, she is the co-chair for the Cancer Committee and the Utilization Review Committee. She is also an associate director for clinical research at the Dan L. Duncan Comprehensive Cancer Center. Thank you so much, Dr. Mims, for joining us. And so I will let you take it over.
Thank you, Brittany. Should I share my slides or you'll share?
Whatever works for you.
Okay, let me see if I can share my own here. Hopefully, are you all seeing my?
Yes, we can see it.
There we go. Okay, great. Well, thank you everybody for joining. I thought I would just give you a little overview of what we're about at Ben Taub and Smith Clinic. I think many of you are familiar with the county safety net hospital system, which consists of two hospitals, Ben Taub and LBJ Hospital, and two outpatient specialty clinics, Smith Clinic and OC Clinic, which is on the campus of the LBJ hospital. And together, these two hospitals and two separate oncology specialty clinics serve the majority of the unfunded cancer patients and underfunded cancer patients in Harris County. So I thought it might be interesting for people to see a little bit about our patient population. In the overall population that we serve, about 44% are uninsured, completely uninsured, and the majority of these folks are below 1.5 times the federal poverty level. About 20 to 25% have Medicaid or CHIP. 20% have commercial and other funding, and about 11% have Medicare or Medicare managed funding. Our patients overall in Harris Health are 31% non-Hispanic whites, 20% non-Hispanic African Americans, 42% Hispanic and Latinx, and I would say the majority of those folks don't speak English, and about 7% Asian. So we have a pretty wide distribution of people we serve, both underserved from the financial point of view and then underrepresented minorities. We got a lot to do. We have two services, our medical oncology service, inpatient, where we consult and also give chemotherapy. And that's run by two fellows, a clinical pharmacist, a nurse practitioner, and usually a resident from medicine. And our census there is 20 to 25 patients a day. So on the inpatient side, on solid tumor oncology, we usually have 20 to 25 patients. On hematology, we do very similar things. And the setup for the team is quite similar. We have one clinical pharmacist who bounces back and forth. Very frequently, not only do we have Baylor fellows, but we also have MD Anderson fellows who are really interested in seeing patients from the front end, and usually a resident. We have a procedure fellow who comes and helps us do bone marrow biopsies once or twice a week. And our census is a little bit larger there, sometimes up to 40 patients, but generally 20 to 30, 25 to 30 patients a day. And this is what our team looked like. Obviously, this photo was taken during COVID, but you can see our clinical pharmacist there in the middle. We have students, and I'll talk about the three students in the front row in short white coats in a minute. Dr. Riggins is standing next to me. We have a number of fellows, and then peeking out from behind are some of our other fellows and a couple of nurses with their masks on behind us. Our outpatient clinics, we estimate more than 400 clinic visits a week, and we really have tried very hard to subspecialize our clinics. So we have breast clinics with genetic counseling in the clinics. We have urology oncology, GI medical oncology. We have two hematology clinics. We have a brain tumor clinic, and we are unique in that we're the only brain tumor clinic in Harris Health. So the patients from LBJ come to us for that clinic. Thoracic oncology clinic, we have a follow-up clinic. We have a diagnosis and screening clinic for patients who have suspicious findings but are not yet diagnosed, and one of our nurse practitioners runs that with us as backup. And then we also assist with the infusion centers where the patients get chemotherapy at Smith and Ben Taub. And we review all the chemotherapy protocols on a rotating basis in a weekly meeting on Monday mornings. And these are some photographs of our outpatient clinic. This is one of the oncology clinic. Again, the students are in the background, several of our fellows, and in the middle is Claire Mock, who is one of our clinical pharmacists. And to the right, also in blue scrubs, is Lauren, who's another one of our clinical pharmacists. A big part of what we do is teaching. So in the heme clinic, we have this multi-headed microscope where we look at blood smears from our patients. You see Dr. Udden there, Dr. Miller Chisholm at the back, several of our fellows and our students. These are our oncology doctors and nurse practitioners. We've got a pretty broad spectrum of physicians. Dr. Riggins, Dr. Miller Chisholm, Dr. Jotwani, Dr. Kamal, who recently joined us, and Dr. Armagani, as well as Dr. Wong, Dr. Kalidas, and Dr. Mandel, and our two really great nurse practitioners, Jenny Nguyen and Danielle Lee. And these are our solid tumor doctors. Our breast cancer doctors, Dr. Nanja, Dr. El-Kanani, Dr. Hoyos, and Dr. Chen, and our two nurse practitioners in the breast clinic, Liz Michael and Tara Anderson. And then on the heme side, we have Mark Udden, Wee Chin Lin, myself, Ludo Mirando, and one of our nurse practitioners, Tia Noor. And we're assisted by our hem-onc fellows. This is the photograph of our fellows from 24, 25. We have 28, I think, fellows right now. We really strive to be to cast a wide net for our fellows. We're very busy clinically, and we're interested in training people who want to be very busy clinically. And I can proudly say we have a wonderful fellowship. Many of our fellows are Spanish speaking, which is super helpful for us, but Others speak other languages, which is also helpful because we have a large immigrant population. So though you see a lot of faces, we only have 6.5 MD salaries to cover all the inpatients and the outpatients. 5 nurse practitioners, 2 are focused on breast, 1 on survivorship care, 2 on oncology, and 1 on heme. And we have 8 fellow salaries that we distribute in parts. So our responsibilities are really first and foremost to take care of our patients. So we have about 1,200 new cancer patients a year in Ben Taub and Smith. And we have built up a large group of survivors. So we don't only serve new cancer patients, but the patients who have long-term survived. And that number is building year to year. We estimate we have about 700 patient encounters a week, which is about 36,000 a year. So we're super busy. We also are responsible for teaching the next generation of physicians, our fellows, residents, and students, not to mention nursing students, pharmacy students, and other sorts of students who train with us. We try to conduct research that benefits our patients in the field, and I'll talk about that. We're responsible not only for caring for the patients, but really organizing the care of the patients and being sure that our clinics and inpatient services run correctly and the infusion center runs well. We serve on committees in Harris Health that influence the direction of care for our patients. We advocate for the patients. And we also link with the community we serve to be sure that we're providing the best care. So we really want to hear feedback from our community as well as from each other. So how do we do all of that? Well, as I mentioned, we have 6.5 full-time equivalents, but we have a lot more physicians than 6.5. And so what we do is we have experts in every field come over and care for patients and take partial FTEs. So we leverage our FTE allocation. Some people come for 1 or 2 half-day clinics a week, but in their level and area of expertise. So we are sure that our patients are getting the highest quality care they could get anywhere in Houston. We work with learners and we really allow our fellows to be the primary hematologist or oncologist for the patients that we serve so that we as faculty supervise, but the fellows really get that one-to-one with the patients, feeling like these are their patients, and we're able to leverage that and care for more patients. And I hope you saw from the photographs, we work as a team, not just physicians, but our nurse practitioners, our pharmacists, our nurses. We act as a team to be sure the care is excellent and affordable for our patients. We're actively involved in a patient assistance program to bring cutting-edge FDA-approved drugs to our patients. And in fact, we as physicians started this program about 20 years ago when we realized that pharmaceutical companies would give drug for free to patients. We started our own little mom and pop business and we kind of got caught doing it. And once Harris Health realized that we could actually get these medications for patients, it became a cottage industry. And ultimately they took it over and they have a whole group of people who help us apply to different pharma companies to get free or decreased cost drugs for our patients. The other thing I don't mention in the slides is that Harris Health has a 340B waiver for our outpatient pharmacy, which allows us to purchase drugs at much discounted prices and provide them to our patients. So the prices for many common chemotherapy agents are much less within Harris Health than they would be at any other pharmacy. And then, as I said, we do active research to improve care at Harris Health via special projects and grants with help from the Duncan Comprehensive Cancer Center. So I'm going to talk about a few of those today. We have looked at how we approach attracting students into the field. We've looked at cancer survivorship and financial toxicity. We have a number of clinical trials available for our patients. So we have options for people who are not insured and don't have any other options. We conduct a number of quality projects aimed at issues we see in the hospital and the clinic. And we also actively participate in groups that support cancer health equity, and I'll talk about that. So one of the projects that I'm most proud of is funded by ASCO, the American Society of Clinical Oncology. And this is a 4-year pilot grant with funding from ASCO that allows us to take 3 to 5 students from Baylor Medical School between their first and second years, in that summer in between their first and second years, to really expose them to oncology care. And we've limited it totally to Harris Health because we're so well integrated. And it's designed to bring in students who are underrepresented in science and medicine as an immersive experience. So they come in and they round with us on the inpatient and in the outpatient center in medical oncology, heme, surgical oncology, gynecologic oncology, radiation oncology, pathology, and palliative care. So they get exposed to all aspects of oncology care. They go to conferences and tumor boards and lectures with us. There is an ASCO curriculum that they partake in. There are groups all around the country participating in this, and they Zoom in for these meetings. They go to the ASCO national meeting, which is in June of every year. And we also have social activities for them. And I would say that the main driver behind this is Dr. Karen Riggins, and Karen is here. These are some photographs of the students in the short coats rounding with us in the hospital. This is my living room showing this is a graduation last year from the ASCO program, and our cancer center director is there in the middle with some of the physicians. There's Dr. Rouse, there's Dr. Hoyos, there's Dr. Ludwig, Dr. Riggins, and myself. Again, in the clinic, here are our fellows with many of the students, having lunch with them and talking about careers, and then having some fun as well. So this is among our first class of students who are graduating this year. We've also taken part in the ASH Mentorship Summit. ASH is the American Society of Hematology, so it's the heme side of ASCO. And we've participated in a mentorship summit and task force, which is a national effort to ensure that all our fellows and junior faculty have mentors, and we have structured processes now for mentorship and mentees. These are photographs from the ASH headquarters in Washington, D.C., where we went for this summit. We have QI projects. We recognize problems and we implement projects to get those taken care of. This is led by Dr. Jotwani and Janine Wong, who's our QI specialist. And this came from an observation that when patients had extravasation of chemotherapy, meaning if it accidentally got outside the vein, which can burn and cause problems, we really had no organized process to take care of that. So we have, as a group with our nurses, created a process. We've revised our instructions. We put a link in our online chemotherapy protocols to lead straight to an instruction document about what to do for any particular medication. And we developed a tool for nurses to use so that we can standardize and search for our results. And this has gone live and has been presented nationally, actually at several ASCO meetings. We've done a lot of things to address disparities for our patients. We started a financial toxicity project that was funded by the Cancer Center to really come up with a tool to help identify patients who have financial toxicity. And we've recently published that tool. It's 3 questions only, but it really helps us administer the tool to patients and then identify patients who really need help and get that help for them. We also have an NIH grant to create a new survivorship paradigm, and we've done that in collaboration with Lee Liu, who runs our general medicine clinics, and Hoda Badr. And this project is really looking at being sure that patients who have cancer diagnoses stay closely linked to their primary care doctors by integrating the primary care doctors into their care. And we also received a supplement to support a young woman who's interested in the area and get her trained to do these kinds of projects as well. We have a grant from CPRIT here in Texas to help fund the non-medical cost of clinical trial participation, and that was a big grant, is a big grant over 3 years, working collaboratively with Harris Health. One of the last things I'd like to talk about is a project that's really near and dear to my health, and that is bringing cell therapy trials to a safety net hospital. Many of our patients are unfunded and don't have access to cell therapy and bone marrow transplant, which is becoming increasingly important in the care of patients. So we linked up with the Cancer Center and the Center for Cell and Gene Therapy at Baylor to create a cell therapy clinical trials project. And so we recognize that cancer patients get the best care at sites where they can access clinical trials. And for many patients, cell therapy trials offer our best possibility of cure. But many patients are severely limited when they don't have insurance. And we also recognize that at a national level, African Americans and Hispanics are grossly underrepresented in cell therapy trials. So very little is known about toxicities and responses in these populations. And we really wanted to move the field forward that way. So again, this is our challenge here. There are about almost 5 million residents in Harris County, and more than 25% have no health insurance, which is amazing. 20% of all people in the county fall below the federal poverty line, but many more of those in Harris Health. And we care for most of those people. Among cancer patients, about 75% are either Hispanic or African American. So a large number of our patients belong to underrepresented minorities. And as I said, fall below the federal poverty line. So not only did we think this would have an immediate effect on our catchment area population, which is in large part Harris County, and enhance health equity in cancer trials and close the disparities gap. But we're really hopeful that if we can come up and make this project really paradigm shifting, it might serve as a model for other cancer centers across the US to reach out to safety net hospitals and offer this life-saving therapy to our patients. So this is sort of our big plan. Again, you can see Dr. Lula here in the Center for Cell and Gene Therapy, Dr. Riggins, several of our fellows and our research coordinators, and Carolyn Thibodeau, who some of you may know. She is the boss of all of my research coordinators in the clinical trials unit. We actually published this in Cancer Cell in December of 23, and this is our plan. We've already started giving patients ex vivo expanded immune effector cells via investigator-initiated studies from the Center for Cell and Gene Therapy. Once we accumulate enough patients, our plan is to get FACT certification and then move toward genetically modified, which would be what we call, they're not CAR T quite yet, but we're planning to sort of step up in intensity and ultimately be able to offer CAR T cells to our patients at Harris Health, beginning first with these investigator-initiated studies developed here, and then moving toward pharma studies so that we can actually support ourselves. And then this is Dr. Lula and me giving cell therapy to our first patient. He allowed us to use his photograph, and he's done extremely well. And then the final thing we've really done is try to reach out to the community. So we've been very active participants in a number of groups. This is one, the B'nai Tara Foundation, which is focused on cancer health equities. This is a photograph of many of us attending the B'nai Tara Cancer Health Equities Conference held every year in Seattle, actually this week on Friday, Saturday, and Sunday. And this is last year. Our optimized study. Dr. Botter is standing here next to me at one of our posters. She presented the optimized study. There were representatives there from the FDA, American College of Physicians, ASCO. There were members of Congress who spoke at the meeting, and we're going again this year, and we're taking residents and fellows as well as faculty to the meeting with us. And I think that's my last slide, and I am going to stop sharing and allow everybody to take part in the conversation.
Thank you, Dr. Mims, for that presentation. So now I'm going to introduce the moderator for today. It is Dr. Nkechi Ogbo. She graduated with a Doctor of Pharmacy from the University of Minnesota and completed a one-year general practice residency at the VA Medical Center here in Houston, Texas. She's also completed a master's degree in public health with an emphasis of public health leadership from the University of North Texas Health Science Center in Fort Worth. Over the past 16 years, Dr. Ogbo has worked in the retail pharmacy setting and pediatric hospital setting before joining TSU as a health education and community engagement pharmacist in late February 2024, where she supports health equity advancement research and training initiatives. Thank you so much, Dr. Ogbo, for moderating today.
Thank you so much, Brittany, for the ask, and thank you so much. It's my pleasure to meet you virtually or in person, I would say. And it's my honor to be able to moderate this session with you, this Q&A session. I've learned a lot. I can say I've learned a lot, and I didn't have any idea of this partnership that Baylor College of Medicine actually has with Harris Health. So if you permit me, I'm going to move right on to asking a few questions concerning what you have presented. And thank you also on behalf of Dr. Ajewole and on behalf of Dr. Rouse and P20 for, honoring us with this really insightful information. So the first question I have for you, Dr. Mintz, is I heard you mention how your team members try to integrate primary care providers into this cancer care continuum. Are there any specific ways you can highlight how these primary care providers are bridged, or pretty much like are put it into the discussion?
So thanks, Dr. Ogbu. So we were very careful in this project to pick three major areas of cancer where we thought there were high likelihood of cure. And so the patients we thought would be, most of them on chemotherapy for a defined period of time with a long period of survivorship in their care. We leveraged the fact that one thing I didn't mention is that we have 2 hospitals and 2 specialty clinics, but we also have, I think, around 25 community clinics. All of us are on Epic, so we can all, in one instance of Epic, interact with each other. So we've done some training of our primary care physicians. We've led some focus groups on what they feel that they need, and we've tried to respond to that. We've built some tools in Epic to interact with them. So for instance, if they have a colon cancer patient, we have an informational letter for them of this patient is getting this particular chemotherapy. These are the side effects of the chemotherapy. These are the potential responses to those side effects. And we've also built tools to allow them to use dot phrases to guide them in terms of care of the patients. One thing I recently spoke at a primary care conference, and I think there is a little bit of a silo between the specialist and the primary care doctor. But part of that is because we as specialists have really focused on our area. We don't know that much about primary care. I mean, I cannot tell you anything about diabetes drugs anymore, right? And the primary care doctors don't understand the chemotherapy agents. So we're trying to bridge that knowledge gap with communication.
That is really cool. Thank you so much. This is really great. And then how do you think the reception has been with this bridge, like in terms of the primary care providers and even the specialists?
So as I mentioned, we are having more and more and more survivors. There is no way for the oncologist to take care of all the new patients who come through the pipeline and all the long-term survivors. So it's a necessity for us to reach out to the primary care doctors. The primary care doctors don't want to lose their patients to us.
Yep.
They don't want the patients with us for 2 years and then they come back and, I haven't taken care of their blood sugar and their A1C is, 15, or I haven't done their pap smear. So I may have treated their colon cancer, but I never did their pap smear or I never did their mammogram. So it's been pretty well received on both sides. We've actually, for some of the lower risk cancers, lower risk of returning cancers, the primary care physicians actually take over some of the visits from the oncologist. So we train them what to do, and they maintain that connection with the patient. So the patients never lose their trusted primary care providers. They stay with them. And I think everybody likes that.
That is really cool. That is really cool. Now, in this project of building this kind of safety net hospital, are there any challenges that the specialized oncologists have experienced, and then how has that been surmounted?
Could you repeat that a little bit? Sorry, somebody's paging
No
me.
problem. So I was asking, what are the biggest challenges in providing specialized oncology services at a safety net hospital, and how has that been surmounted?
Yeah, so I think like any other care, we have to be cost conscious about what we do. So you heard me talk about the patient assistance program to get
Right.
free care. So we look for those kinds of opportunities. We think about if there are 4 alternatives for treating a patient, all other things being equal, we use the less expensive one because we understand the physicians, and it's important for the fellows to get this kind of training too, that we have to be cost conscious about medicine. One reason we've kept our ASCO OSI students at Harris Health is because we're better integrated than any group. I think we understand the need to work in teams. We understand the need to listen to the pharmacists and the nurses. We understand the impact of social determinants of health on care. And Harris Health has really been wonderful. They've developed a food pharmacy for patients who have food insecurity. We talk to patients about, because people aren't compliant when they're hungry.
Right.
When they have to go to work and feed their kids, they can't be compliant with care. So we try not to just address the cancer care, the medical part, but also the social part as well. And Harris Health has been great about helping us do that.
That is really cool. That is really cool to know. You mentioned something that honestly piqued my interest, and I just can't help but ask. You mentioned about, trying to be cost conscious. And I remember something like, because I did have the privilege of helping verifying orders in Beacon when it comes to like, oncology orders and stuff. The question is that have even in determining cost consciousness or trying to be cost conscious, sometimes like, when a protocol is written, let's say in meter squared or whatnot, and then, there is a rounding up. Sometimes the rounding up can cost like 2.1 mLs, and let's say like a vial is just 2 ml. Has that be taken into consideration in terms of telling Epic go down to 1 vial because 0.1 ml of drug could not make any difference?
Yes. So we have clinical pharmacists who work with us in the clinic and in the hospital. So we have been very cost conscious. So we tell them, we have dose rounding protocols that everyone knows about. And our pharmacists, sometimes we have to delay waiting for the free drug. Sometimes we may have to delay 3 or 4 days to get drug. People have this idea that only in safety net hospitals do people wait. That's not true, right? Even outside, even when you're dealing with insurance companies, people wait for their care. And so I don't think we look carefully at our outcomes compared to national averages. Our cancer program is certified by the American College of Surgeons Commission on Cancer. So our cancer registry reports to the Commission on Cancer, and we can see our outcomes compared to national averages. And we're doing at least as well, if not better, than the national average. And we keep our eye on that because we don't want to be, we want to provide good care for our patients, and we want to allow people to have cutting edge care as well.
That is very great and encouraging to hear. And I'm very happy that you spoke about the cancer outcomes being comparable to those who are not, in safety net hospitals. Now, the next question I have is, what policy level changes could improve comprehensive cancer care in safety net systems?
Well, obviously, I'd love to have more money, right? So if they raise tax rates, right? If we had, I think I think we do a lot to leverage community services. We are just about, I'm really excited about this. We are just about to enact our partnership with CanCare. CanCare is a community foundation that pairs patients with survivors of the same cancer. So these folks don't ride them around and take them back and forth. They provide emotional care for people.
Oh, wow.
So I think linking to the community services, the Houston Food Bank being a good example, foundations out in the community, listening to our community partners in terms of what's valuable to patients, asking our patients, and ensuring that we're leveraging what's in the community as well as what we have funding for. And we hold each other accountable too. I mean, we just had a P&T committee today, and we looked at the spend, how much we're spending. And we looked at all the high dollar cancer drugs, and we said, are we using the PMAP program to our best advantage to get each one of these drugs, make sure every patient eligible is approached and enrolled so that we can get free or low cost drug for them. So I think money, just like any other business, money is always the source, but I think it's being smart about how we spend it.
Yep, exactly. I agree with you 100%. Now I have a question. What other partnerships, be it academic, nonprofit, or governmentals, can help to bolster the services we're talking about? I heard you mention CanCare. I heard you mention Houston Food Bank. Are there any other partnerships that we would not have even imagined, that you guys are also currently leveraging?
So the American Cancer Society, of course, the American Cancer Society is great. We have a cancer resource center at Smith Clinic, and it provides wigs and prostheses and links to outside services that we may not be totally aware of. We have a music therapy program. We have a survivorship care nurse practitioner, and she runs an art therapy program for our cancer survivers. We have one of the things I'm most excited about and love is we have pets who come and visit in the hospital to cheer patients up. So once or twice a month on a Saturday, we have our dogs come through, and they're all trained, to work with the patient. So we have all kinds of partnerships. I mentioned ASCO, ASH, our professional societies. We'll take anybody and everybody who wants to help us.
Wow, that is really cool. Thank you. For my follow-up question, and how is this great information that you just shared with us being shared with other community members? I know that our primary care physicians are being looped in, but then how can a lay community member know to that these services is being provided all? Because hearing something like this would make me want to go and receive care from, Harris Health, knowing that you guys are partners with them versus someone else or another place.
That's a really good question. And that's probably an area we don't do as well as we could. You know, we have a community advisory board within the Cancer Center. And we work with Dr. Rouse, and we all try to go out to community events, you know, church events, health fairs, and things like that. But I think a lot of people still think about us as sort of a mash tent out on the prairie or something, and we're not. We're a pretty sophisticated cancer program where patients, think about it, we're training the people who are going to go out and be your cancer doctor sometime in the future. So we have to train them at the highest quality care, how to do the highest quality care. And a lot of their training happens within Harris Health. So yeah, I think we could do a better job linking ourselves to the community, but that's, you know, through our advisory boards, I think that's where we really have our biggest impact.
That is really cool. Thank you so much. Thank you so much for this information. This has really, really been impactful and eye-opening and enlightening. You mentioned how you guys all when it looks at when it comes to outcomes, that your outcomes has been comparable to those, you know, non-safety net hospitals. Are there some specific quality metrics that you guys use as standard of care or to measure that you remain up to par?
Yeah. So, I mean, we keep a very close eye on overall survival rates, right? So that's probably the most important thing for patients, but also progression-free survival is also important. So patients, you know, stay in remission longer. Those are the, you know, we look particularly in clinical trials, we look at adverse events related to the clinical trial, side effects, and those kinds of things. But I would say probably the most important thing to patients is to know, if I have a curable cancer, are you going to be able to cure me?
Yeah.
And that's something we all take a really careful look at nationwide. So every cancer program that is certified by the COC, the Commission on Cancer, is required to put their outcomes into a large database that we can all access and view and compare ourselves. We have dashboards where we compare ourselves to those things. So we look at, on the big picture, we look at survival, but we also look at infection rates and, you know, clotting. We've got a huge project I didn't even mention to look at. We put a lot of central lines into people, and cancer patients get a lot of blood clots. We're looking really carefully at the rates of blood clots, for instance, in our patients, infections from central lines, infections from Foley catheters, all those things we are also looking at in our cancer folks.
Thank you so much. Really insightful. Thank you. Thank you. To sum it all up, I just have one more question I'm going to ask you for myself. If I were to go speak to somebody about what we just discussed in terms of explain to somebody what a safety net hospital is, can you give me one sentence I can use?
So, you know, so a safety net hospital is the place that people who are unfunded or underfunded go for care. That that is what we do.
Much. Awesome.
Yeah.
Thank you. A place where someone who is underfunded or unfunded goes for care. And that's it. It's what a safety net hospital is. Thank you so much, Dr. Mims. Thank you so much for your time. Really appreciate you taking our time. And even despite the call you got, but thank you so much for everything. And it's really been insightful. Please feel free to send your questions if you have any extra questions. And I'll be more than happy to forward that to Dr. Mims later. But thank you so much for your time, Dr. Mims. And I'm going to round us off of today's webinar.
Thank you.
Thank you so much. So next, that concludes April's webinar on comprehensive cancer care in a safety net hospital, healthcare delivery at all levels by our most esteemed Dr. Martha Mims. Please feel free to click on the link in your in your chat group where you can please help us and fill out the survey about this. And for those community health workers who are wanting credit, please go ahead and also fill the sign-in and attendance link. We will get back to you in less than 2 weeks with your CE credit. Next slide, please. Now, I just want to briefly touch on Texas Southern University's Clinical Research Registry. So it's a clinical research registry where the type of data repository where participants are enrolled in a database or registry, and we're just collecting and storing detailed information over a specified period. Now, this information could include your demographics, your contact information, medical history, and other relevant data. And what is it done to? It is just to help establish a comprehensive and diverse database of potential clinical research participants. So if you're interested in moving the needle, be it in cancer or any other disease condition, Texas Southern University Center for Clinical Research and Translational Sciences is a place to be. So now this registry will serve as a valuable resource for identifying individuals who may be eligible for participation in various clinical studies. And this could be ranging from just observational studies to interventional trials. And we seek to recruit individuals with a wide spectrum of medical conditions, both past and present, as well as healthy volunteers. And please, you need to be 18 and older to be able to join. Feel free to click on to scan the QR code here, or even in the chat group we have put in the link tree if you want to hear more about this great opportunity. Next slide. And we have some other upcoming events by our community engagement core. Now, September 13th is going to be our Let's Talk About Prostate Cancer outreach event taking place at Progressive New Hope Church. More information is also in our link tree. And then October 31st from 11 a.m. to 3 p.m. on Texas campus is going to be our 5th We Roar Against Breast Cancer. And please, please, please feel free to join us virtually if you can't make it in person, but we are more than excited for these events. It's always engaging. There will be mobile units, there will be speaker sessions, answering your questions, and participating in all our different vendors who will be there as well. Thank you so much. And please go ahead and click on any of these QR codes to register for this event taking place in the next few months. And with that, I will close us out. Thank you so much. Thank you, Brittany, for hosting this. Thank you to our P20 PIs. Multi-PIs, Dr. Rouse and Dr. Ajewole. And feel free to, if you want to listen to this again or watch us again, please go ahead to our YouTube pages. And we are there online. Have a blessed one. Thank you. Bye-bye.